Hello and welcome to the study of medical massage therapy. In this program, we will be concentrating on medical massage therapy 2, upper extremity pain and dysfunction. In this course, we concentrate considerably on entrapment neuropathies of the upper extremity and other pathologies that pertain to the shoulder, arm, wrist, and hand. The first thing that we do when a client comes in, generally speaking, after taking a history and gaining an understanding of what has brought them to the office today, we want to get an idea of their active range of motion, what they can normally do with that particular part, in this case, the upper extremity. So the first thing we'll be doing today will be active range of motion, followed by passive range of motion, and then manual resistive tests, and finally, special regional tests that pertain to specific problems in the upper extremity. External rotation, internal rotation, external rotation again, very normal, and back down. Turning to the elbow, I can bring it into assisted flexion and relaxed. I can move the wrist into flexion, into extension, and I can move the fingers into flexion and extension. So that comprises passive range of motion. A manual resistive test tests the contractile structures, where the passive range of motion tests the inert structures like the bursa, the joint capsule, the ligamentous tissue. So we'd like to distinguish between those, and that's the way to do that. Next is the empty can test, whereby she holds 2 imaginary cans of soda and then turn the cans upside down, and then I reach over and resist to test for supraspinatus tendinosis. If the arm had a rotator cuff tear at the supraspinatus or a severe injury to the supraspinatus, she would barely be able to get the arm up, and then she would start to move, and then it would just drop, just let it drop. That's what would happen. She would not be able to hold it. So that's why it's a very, very good test. Next is the Finkelstein test for de Quervain's tenosynovitis. De Quervain's tenosynovitis, teno, tendon, sino, synovial fluid, and itis, inflammation. An inflammation at the base of the thumb, and it's performed like this. If you'll do what I do, please. Close your fist around your thumb in that fashion. First, move it down in that fashion, not at the shoulder, not at the elbow, but just at the wrist. Your movement is right there, and then you move down. This is a 2-part test. If there's discomfort here on the movement of going down, it's a positive test. If there was no pain when she moved down, then I will move in to resist this motion. So her motion is going to be to come up, and I'll resist to see if it produces pain at the base of the thumb. See that part right in there where the brachialis is? Exactly. Yes. I can even change hands. She pushes. Yes. Moving to the pectoralis minor, I want to show you how to reach the pectoralis minor every single time. And that is to have the client's elbow pointing in the air. Place your hand on her thorax, just under the armpit, in back of the pectoralis major. Here's the pec major, so I place my hand just posteriorly to the pec major. You see, I'm sinking into a space there. Now, with the elbow pointing to the sky, I simply move her arm forward like that, and my fingers end up exactly on pectoralis minor. In the side-lying position, you may be able to reach the levator scapula and the rhomboids on your client. It depends on 2 things. One, if the client is not overly hypertonic or tight to allow some slack in the rhomboids to get up under there, and also the strength of the therapist. Some folks are not able to get the sufficient strength to do this technique. However, many can, and if you can, it's a very, very good one. So we'll begin with the hand right there on the body, not leaning over there because that puts it on stretch. We want to put it on slack, and then I place a little pressure here on her front of her shoulder and loosen her up just a little bit to get up under there like that. And once there, I can curl my hand over and move that entire scapula as I'm under the edge of it. Here's the way the fingers look underneath, and here's the way it looks with my hand covering it. All along the rhomboids, pulling the scapula away from the body. They so often get stuck. We'd like to help pull that scapula away from the body. In addition, coming up here to the corner of the scapula, you see, as I press, if I outline it, we have the rhomboids along the internal medial border, and then at the corner, the medial corner, we have the levator scapula that just popped under my fingers. So there it is there. I can cross fiber the attachment of levator scapula. I can pull on it. I can mobilize the shoulder and push it over my hand about like that. Some scapulas are easier to get under than others, but that's a very good technique if you can get under there. Taking this out and moving it up just a little bit more under the shoulder like that, so that we create a slack now in the rhomboid area and in the posterior aspect of the scapula where the infraspinatus and teres minor lay. We can find those rotator cuff tendons just about where that band is on this shirt. Right there for teres minor, right there for infraspinatus, and right here for supraspinatus. Can treat from the prone position the tendons of those three important rotator cuff muscles. Can use the forearm to lean into that junction of the scapula and the arm and do some mobilization work and just leaning or compression. Laying on the scapula and right off into the shoulder. Here's the lateral border of the scapula, and just on the lateral border is the teres minor. Place the fingers there at the scapula, roll on the scapula for teres minor, and off the scapula for latissimus dorsi and teres major. And here they are. Just like that. So the two sets of fingers can easily lift latissimus dorsi and teres major, and roll that with the fibers and across the fibers. If you find a trigger point, like perhaps right there, hold, pressure, ask the client to breathe, and indicate when it's releasing or diminishing. So the goal here in the prone treatment is to move the scapula. The muscles that connect the scapula to the trunk will tend to cause it to fixate and be stuck. So we want to work the lateral border, around the side, the medial border, and all of the areas of the scapula to allow it to be able to be more mobile and liberating the muscles that are connected to the trunk. For overuse injuries of the shoulder, in addition to stretching the internal rotators, it will be helpful if we assist the client in strengthening the external rotators. The external rotators of the shoulder, infraspinatus, teres minor. So we ask her to place a small weight in her hand. This is a 2-pound weight, and she will lift that weight up to strengthen the external rotators. So begin, raise it up, only as high as you can go, and down. Nice, slow movement. Again, bring it up. She goes as far as she can, and if she can do 5 of them, please continue, do 5. If she can do 2, do 10, do 10. Once she can do 10, try 2 sets of 10. Then try 3 sets of 10 to strengthen the external rotators. If her injury is significant enough that even a 2-pound weight is a lot of weight for her to lift, a simple bottle of water that weighs about 12 ounces can be a good starting point. Anything that she uses to raise will work very effectively in beginning to strengthen the external rotators of the shoulder. The goal for treatment of the upper extremity and the scapula is to be so thorough that we reach every single muscle in the upper arm and the lower arm, wrist, and hand. If we treat each muscle group, we are then going to have a greater likelihood of finding the trigger points that will refer pain to the areas that are bothering our client. We will have greater chance of freeing up the fascial constrictions. We'll have greater chance of increasing mobility in that upper extremity and in all the joints of the upper extremity. And our goal is to work every single area. You notice that we got all around the scapula, above, below, around the rotator cuff itself, and all through the upper arm, lower arm, wrist, and hand. By this form of specific treatment, we're able to encounter and hopefully correct entrapment neuropathies, which is muscle tissue entrapping or impinging a nerve, maybe a tiny nerve, and yet that can cause significant problems in the arm, wrist, and hand. So our goal here has been to be thorough. We would support that with the exercises that we've done. We covered assessments for the area, and I hope that you enjoy using this work with your clients and getting the kind of results that you would really like to be getting on a consistent basis.